Hello friends, good evening. Let's crack NEET PG. Welcome to Unacademy. I'm Dr. Shonali Chandra back with another session of mixed bag MCQs pertaining to malpresentations. I have highlighted my referral code here, that's SHONALI. So if you take a subscription from the Unacademy platform, you can use this code to avail a 10% discount on your subscription package. You can also download the Unacademy learning app on your mobile phones and you can get notified about the upcoming special classes, crash courses, batch courses as well. On the platform, you'll get daily live classes where you can interact with your educator, ask your doubts and queries, all the while that the class is going on. The courses are structured keeping in line with the latest NEET PG syllabus. Live tests and quizzes they get conducted on the platform regularly, so you can evaluate your performance as you go along. And one-time subscription will give you an unlimited access, so you can watch all the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All subjects that we need to prepare for our post-grad entrance examinations, they're covered. Every now and then comprehensive batch courses as well as short duration crash courses, they keep getting launched. So to give you an example of the kind of courses that are being conducted, so you can see here there's a focus batch for FMG 2021, a short duration course which started in the month of Feb. There's a crash course that's last mile to crack NEET PG 2021 for the upcoming examination, which is scheduled to take place on April of 18th. And you have a target next batch, also longer duration batch courses for targeting the next exam to be conducted in 2022. Now there's an evening batch as well as a morning batch, so you can choose any batch depending on your requirements. If you subscribe using my code, you can also get a 10% discount on your subscription package. Now there's a new module of subscription also, which is the iconic subscription. It allows you to access Unacademy and Prep Ladder at the same time. Now you can take this iconic subscription for 12, 18, 24 or 36 months duration. And if you subscribe using my code, then you can avail a 10% discount also on your subscription package. And talking about the NEET PG Plus subscription modules, well, again, you can choose one depending on your needs and requirements. Like for example, if you are going to sit for the upcoming exam, want a crash course, you can take the 1 or 3 month duration subscription. If you're targeting the next exams, you can take the longer duration packages like 12 or 18 months. It will give you ample time to go through all of the sessions, leaving you enough time in the end to revise as well. And as you can see, on a monthly basis, it turns out to be more economical also. And for those of you, who are in your third year or final year MBBS, or you're simultaneously doing a job and working, you want a slower pace of preparation, then you can take the 24 months duration package. It turns out to be far more economical in the longer run. And if you subscribe using my code, you can avail a 10% discount on any of the subscription packages that you choose from. While on the platform, you can also check out the special classes which are getting conducted on the platform. These are free, so you can come and access them on the platform. There are various capsule courses, detailed theoretical courses that I've conducted, and to gain access to them, you'll have to subscribe to the Plus course, and you can use my referral code to avail a 10% discount on your subscription package as well. So good evening everybody here. So I can see Dr. Sanam, I don't know if you've rejoined again or no as of now, but Roshni, Dr. Musarrat, Suvarna, Panduka and Aisha, good evening to you guys. And let's get started with the session for today, a mixed bag MCQ session to quickly help you revise and think about the various malpresentations which we encounter during labor. So let's get going and let's start a quiz. And let's have a look at the first MCQ of the day. A multiparous woman comes in labor. She's admitted in labor, in advanced labor with breech presentation. The fetus is delivered without assistance as far as the umbilicus, and the remainder of the delivery is assisted by the obstetrician. What is this called? Is it called version and extraction, spontaneous breech vaginal delivery, partial breech extraction, or total breech extraction? So what is this called, guys? Multiparous woman, or any woman who's been admitted to the LR with advanced labor with breech presentation. She's delivering vaginally. The fetus is delivered without assistance as far as the umbilicus, and the rest of the delivery is assisted by the obstetrician. This is partial breech extraction, okay, or also called as assisted breech vaginal delivery, okay, in which the delivery of the legs, the buttocks, and the trunk happens spontaneously, okay, and the delivery of the arms and the head is assisted by performing maneuvers by the obstetrician, right? Total breech extraction is when the buttocks, legs, everything from the beginning go are delivered by performing maneuvers by the obstetrician. That becomes total breech extraction. And spontaneous breech vaginal delivery, which is not assisted, would be that the breech is allowed to deliver absolutely all its own with hands off, okay, and no maneuvers done at all. Now, spontaneous breech vaginal delivery is only to be done in case the fetus is of not a concern. In extreme preterm cases, when the fetus is deemed non-viable, right, then only spontaneous breech vaginal delivery is recommended. Otherwise, all breech deliveries, when conducted vaginally, are either conducted by partial breech extraction or by total breech extraction, okay. So spontaneous breech vaginal delivery is only for such preterm fetuses, such extreme preterm fetuses which are deemed non-viable, okay. Otherwise, all breech deliveries are either total breech extraction or partial breech extraction, also called as assisted breech vaginal delivery. All right, Sadia. So I think I've repeated it again for you here. Now, moving on for the next question. There's a 28-year-old third gravida para 2 live 2 woman who's seen at 38 weeks. The fetus is in breech presentation with breech well down into the pelvis, and the uterus is irritable. On PV examination, the cervix is uneffaced, os is closed, and the pelvis is adequate. Ultrasound confirms a healthy fetus in frank breech position with a well-flexed head. Estimated fetal weight is about 3 kgs. The amniotic fluid index is about 12 centimeters. So counseling about the delivery management, what would not be offered to the woman? Expectant management, cesarean section, external cephalic version, or internal podalic version? Yes, guys. So Roshni, have a look at the option number D again. Right, you're choosing option number B here. I'm asking you to have a look at internal podalic version again, right? This is only and only done for the only situation where this method is recommended is in the second twins being transverse. So you will not counsel our internal podalic version at all. The only indication in obstetrics is delivery of the second twin in transverse lie. Whereas in this woman whom you are seeing, she is multiparous, you're seeing her at 38 weeks, the fetus is in breech presentation, right? The pelvis and uterus, pelvis is adequate, she's only getting, not even mild contractions, the uterus is just irritable, right? So the actual labor has not even begun. Your os is entirely closed. Your ultrasound confirms your breech presentation, well flexed head. It's not like it's a very big, huge baby also. It's 3 kgs estimated fetal weight. The liquor is also adequate. So counseling will be taking into consideration all of these factors, right? She can choose to go into spontaneous labor. That would be expectant management. So spontaneous labor and a breech vaginal delivery is also an option for her. She can choose to go for a cesarean section also. You see, when you're counseling women like this, and she would ask you, Doctor, main kya karu? Should I go for a breech vaginal delivery? Should I go for a cesarean section? You say that there are options available for you, right? You can choose to deliver vaginally, right? There's no problem in that. But then you have to understand and you have to tell the woman that there are risks associated with breech vaginal delivery, like there's risk of cord compression, there's probably a risk of cord prolapse, there's risk of fetal injury and this and that, there's a risk of head getting stuck. And if she is willing to agree to those risks, right? She can go for a breech vaginal delivery, right? She can go for a cesarean section also. She says, no, no, doctor, I don't want to take such risks with breech vaginal delivery. I don't want to take those risks. Do a cesarean section for me. I'm not willing. So the option of having a cesarean section is also available, right? And performing an external cephalic version is also available. So all pregnant women who are identified as breech at term, they should all be offered external cephalic version if the criteria for external cephalic version is met, right? So there is no problem in her being counseled for either spontaneous breech vaginal delivery, that is assisted breech vaginal delivery, or she could choose for a cesarean section, or she could choose for an external cephalic version. But for external cephalic version, the criteria should be met. Okay, so all of the options are open to her, but not internal podalic version at all. So what is the criteria for external cephalic version? I mean, does this woman satisfy the criteria for external cephalic version? Yes, guys, have a look at this scenario again and tell me, does this woman that we are discussing satisfy the criteria for external cephalic version? Yes or no? And if no, what information is missing? If no, what information is missing? Does this case, does she satisfy the criteria for external cephalic version or not? If not, you have to tell me which key information is missing. Yes, guys, anybody? She is more than 37 weeks, right? That has been completed. All right. What else? The woman is multiparous. Otherwise, no vital characteristics of the woman have been given. But I would assume that she's a healthy mother. Let's assume she's a healthy mother, right? There's a healthy fetus. Baby is also okay. Healthy fetus, right? What else? The liquor is adequate, right? The pelvis is adequate. So what criteria is missing? Anybody? Placenta, very good. So we don't know whether the placenta is not lying or not. So that criteria is missing. In this case, there is no information given regarding the placenta, where it is. So placenta should be in the upper segment. Placenta should be in the upper segment, right? So this is the criteria, right? So these are the prerequisites that should be satisfied. Now, membranes. Yes, membranes. If liquor is adequate, that in other words means that there is no history of leaking and the membrane should be present. However, for the membranes to be present, you see here the os is closed. So I'm relying on the history that there is no history of leaking. The AFI is adequate, the os is closed, so membranes are obviously present. If in the question they specifically tell you that the membranes are absent, the os is open, you can feel the membranes are absent, or there is history of leaking, then the criteria doesn't hold. So liquor adequate or membrane should be present. That's also a criteria. Now the other thing here, Dr. Sanam, presenting part in the pelvis. Yes, very good. That's a very, very, very good doubt that you have raised. Breech well down into the pelvis is not a contraindication for external cephalic version. Once you do the external cephalic version, one has to lift up per abdominally, put the hands beneath the, try to go into the pelvis per abdominally, try to lift off the presenting part, right? So that has to be done. So breech going down into the pelvis is not an absolute contraindication for external cephalic version. One can try that. Okay. Okay. So now let's have a look at the other important information here. The other important information that I wanted to ask you is well flexed head. And the breech is in fetus is in frank breech. In which kind of breech do you do a cesarean section? In which kind of breech do you do a cesarean section? When do you do a cesarean section in breech? So our woman, every option was possible for her. What if she had a footling breech? What if she had a footling breech? Then you would do a cesarean section. What if she had a breech with extended head? Then also a cesarean section is done. All right. And there are certain indications where cesarean is not absolutely indicated in a breech, but cesarean section is preferred. Cesarean section is also preferred in cases where there is a large fetus. In cases where there is a large fetus, which is approximately about more than 3,800 to 4,000 grams, right? If there is a history of previous cesarean section, if there is a viable, healthy preterm fetus, and the woman has gone into active labor with that preterm fetus, or maybe it's an indicated delivery that is being done. Let's say, for example, there is a woman at 32 weeks with the preeclampsia, severe preeclampsia. You're indicated delivery, you're performing an induction of labor, doing an indicated delivery for a healthy, viable preterm fetus in active labor. The other indication where cesarean section is preferred in breech is severe fetal growth restriction. Severe fetal growth restriction. Right? And yes, Sanam, you're rightly saying breech with extended head. That's another stargazer breech. That's another stargazer breech. All right. And then the other is if there is a fetal anomaly. Let's say there is a fetal anomaly which is incompatible with a vaginal delivery. Incompatible with a vaginal delivery. Right? Or there is a history of prior, abnormal obstetric outcome, like there's a prior perinatal death, right? Or a neonatal birth trauma. Then also, preference is given to a cesarean section with breech, right? And of course, if there are direct indications for cesarean section, like if there's a placenta previa with breech, then that's a direct indication for a cesarean section. Like for example, if there is an inadequate pelvis with breech, then it's a direct indication for a cesarean section. Or if it's twins with first breech, again, it's a direct indication for cesarean section, right? And like I said, preeclampsia, if you are inducing a woman with preeclampsia and she also has breech, cesarean section is preferred in those circumstances, right? So these are the indications of doing cesarean section in breech. These are the absolute indications, right? And these are the situations which I've highlighted where cesarean section is preferred in breech conditions, okay? And Dr. Sanam, fetal distress किसी भी position में होगा, किसी भी situation में होगा, that obviously for the distress you're going to do a cesarean section, okay? Clear on this? Now let's have a look at the next question. A 30-year-old unbooked multigravida comes to the labor room at 38 weeks with labor pains. Before going on to that, Dr. Sanam, precious pregnancy along with breech. It's one way to remember it, but you should not answer like this in front of the examiner because every pregnancy is precious, isn't it? Should not answer like that in front of the examiner because for a woman, each and every pregnancy is precious, okay? So yes, if there's a prior perinatal death or neonatal trauma that has happened, then preference is given to a cesarean section, right? And like somebody said, primey with breech. Primey with breech, no. There's no reason to go for a cesarean section in primey breeches. It is usually done, right? But please give preference to the possibility of external cephalic version, okay? After fulfilling the criteria. Now, coming to the question again. There's a 30-year-old unbooked multigravida who came to the labor at 37 weeks with labor pains. She is sure of her LMP and her previous cycles have been regular. She had 2 prior normal vaginal deliveries. On per-abdominal examination, the fundal height is 30 weeks, the pelvic grip is empty, and the fetal heart rate is 140 per minute, which is heard just below the umbilicus. She is getting mild uterine contractions. What do you do next? You proceed with per-vaginal examination, proceed with an urgent ultrasound, proceed with spontaneous progression of labor, or proceed with immediate cesarean section. What do you do next? Yes, unbooked multiparous woman, term, right? Per abdomen fundal height less than the expected period of gestation. Clue is that the pelvic grip is empty. The other clue is that the FSH is normal, but it is heard just below the umbilicus. She's getting mild uterine contractions. What do you do next? Very good, Farah and Suvarna. You proceed with an urgent ultrasound. Why? She's unbooked. You don't have any ultrasound report available. You don't know if there could be a placenta previa, isn't it? Right? So the most common cause of this situation, what is this situation? Pelvic grip being empty. Most common cause of this situation, which is transverse lie at term, is actually a placenta previa. Right? So overall, if you consider all the causes of transverse lie, overall the most common cause of transverse lie is prematurity. Right? But for a woman to have transverse lie at term, the most common cause is placenta previa. And if I find placenta previa in this woman, right, I will indeed, yes, do a cesarean section only for her. Transverse lie, there is no mechanism of labor, you see. I will have to do a cesarean section for her, even if she's placenta previa or even if the placenta is in the upper segment. But this information is vital for me, because then I have to do a cesarean section. I'm anticipating a placenta in the lower segment. I'll be better prepared for it, right, while doing the cesarean section. Secondly, of course, I'll keep blood ready, because now I'm expecting this woman possibly to have, more blood loss during delivery also. So this vital information is extremely important before going ahead with the ultimate management. In this case, that would be a cesarean section. So first preference given to performing urgent ultrasound. And Dr. Sanam, to confirm the presentation, see, the utility of ultrasound here for me is finding out the location of the placenta, right? The clinical findings are enough in most circumstances to diagnose a transverse lie. Look at this figure here. Look at this figure here. When you're doing a per abdominal examination, by doing your Leopold's maneuver and the obstetric grips, you can clearly feel the fetus's head in one of the flanks. All right, round head, right? You can feel, this is the umbilicus, and you will hear the fetal heart reflected from the backside of the baby, and you're going to hear it somewhere near the umbilicus, maybe slightly below the umbilicus also, right? And your pelvic grip, this is the lateral grip that is being performed. If I were to do a pelvic grip, or if I were to do a pollic grip, where I'm seeing the presenting part here, this grip would be empty. So such clinical examination findings are enough to diagnose transverse lie in most circumstances. Yes, in particularly obese women sometimes. Kabhi women can be very obese, na? And then abdominal palpation might not be too informative. In those circumstances, yes, you want to confirm the diagnosis with an ultrasound, right? Otherwise, the utility is to find out the location of the placenta. Clear? All right. Now, let's have a look at the next question. A 25-year-old primee is seen with transverse lie on clinical examination at 37 weeks. Which of the following statements is not true? Perform ultrasound to confirm the diagnosis. Now read the question line that they're telling you. Is she seen with transverse lie on clinical examination at 37 weeks? Which of the following statements is not true? Perform ultrasound to confirm the diagnosis. Transverse lie is associated with placenta previa. Perform cesarean section with onset of labor. During cesarean section, deliver as breech. Admit for safe confinement. What do you think is the false statement out of all these statements? Which is the statement that you would pick to be not true? Yes, guys. Okay, so Varna, if you don't want to do cesarean section with the onset of labor, when do you want to do it? Think about that also. Transverse lie hai, she is 37 weeks. If you don't want to do a cesarean section with the onset of labor, when do you want to do it? Right? That is my next question to you. Anybody else, which of the following statements is not true? So transverse lie is associated with placenta previa, we just discussed. That's a true statement. All right. Performing ultrasound to confirm the diagnosis when your clinical examination is telling you that she's transverse lie on clinical examination. You want to perform the ultrasound to confirm the location of the placenta. To confirm the location of the placenta. Okay. So when they're giving you that information, can be transverse lie hai on clinical examination. You don't want to perform ultrasound to confirm the diagnosis, but you want to do it if at all to find the location of the placenta. So this statement here is the false statement out of the lot. All right. Now let's go ahead and look at the other options. Right. Now for a woman who is transverse lie and she is seen in active labor, right? Then of course, if a cervix has started to dilate, you see, then one needs to do for a cesarean section only. There's no other option because there's no mechanism of labor in transverse lie. And secondly, if I were to say that, I'll just take my own sweet time in taking up this woman for cesarean section, right? She has come in labor. I want to wait 1 hour, 2 hours, 3 hours for no reason. Why would I do that? What is the risk? What is the risk? Why do I want to do a cesarean section with the onset of labor? Why? Because there is risk of cord prolapse, right? Because there is risk of cord prolapse. So I would perform cesarean section with the onset of labor. True. Onset of labor. True. Okay. That's why we wait, that's why we don't wait for labor to become advanced labor. So we perform the cesarean section with onset of labor. That's also a true statement, right? Now, what if there was a woman who was transverse lie and she was not in labor? Like this woman, 37 weeks, she's not in labor. Then what are the options? What are the options? What are the options? Let's see for this woman. What are the options? Transverse lie, I've seen her. She's not in labor. What are the options? What are the options, guys? Anybody having another option other than cesarean section? Any other option other than cesarean section? Can't we do external cephalic version? Can't we do external cephalic version even in this situation? If we can do it for breech, why can't we do it for transverse lie? In fact, with transverse lie, it is easier. All you have to do is move the fetus head from here till here. Isn't it? So we can go for transverse lie, not in labor. External cephalic version is a very good option, right? And that has to be done after fulfilling the same criteria that we discussed with breech. The same criteria will apply. Right? Now, supposing this woman is not agreeing for external cephalic version. Let's say, supposes this woman does not give consent for external cephalic version, or she does not fit the criteria. Or she does not fit the criteria. Then what should I do? Then what can I do? Then I have no other choice but to go for a cesarean section. The question is when? Right? So ideally, I will admit her for safe confinement because now she's already 37 weeks. So women with transverse lie who are more than 37 weeks, they are admitted for safe confinement because they can go now into labor anytime. And if I were to send her home and tell her to come, it will all depend upon how far she stays, what are the travel options available, can she come immediately, will she able to come or not, what will happen in the meanwhile when she's at home and she goes in labor and the cervix dilates and the membranes rupture and cord prolapse happens on the way to the hospital. So ideally, she should be admitted for safe confinement then in that situation. If we are not able to do external cephalic version, 2 reasons: she could not be fitting the criteria or she does not give the consent. So she is admitted for safe confinement, right? So that's also a true statement. Now, once she is admitted, I can do the cesarean section with the onset of labor. True. As in when she goes into labor, I'll do the cesarean section. She's 37 weeks today. It has been a week after admission. It has been 2 weeks after admission. If I have to do an elective cesarean section, what if she doesn't go into labor anytime soon? Then if at all you have to do an elective cesarean section, one should always wait for 39 weeks to get completed. Okay, if you have to do an elective cesarean section, it always has to be done after 39 weeks have been completed. So for that, 2 more weeks are left. That's why admit for safe confinement is true statement, right? You do a cesarean section with onset of labor, that's also true statement in itself. Okay, if at all you have to do an elective cesarean section, then it has to be delayed till 39 weeks are completed. And during cesarean section, you see, it's a transverse lie. So how do you deliver a transverse lie patient section? How will you take that baby out? You will not be able to grasp the head because the head is here in the flank. All right. So from that uterine incision, you see, when you will try and grasp the head will not come in your hand at all. It will just फिसल जाता है. How to deliver a transverse lie during cesarean section is grasping the feet. You grasp the feet and bring the baby out and deliver as breech during cesarean section, and that's also a true statement, right? So out of all these statements here, we have established that option number A is the only statement which turns out to be false. Rest all statements by themselves, individual statements, are true. Clear on this? Any doubts regarding this question? All right. Now, if there are no doubts, I will move on to the next question. Pelvic examination findings in a right occipito-posterior position will include all of the following except. Now, let me give you a hint here. Even if you don't know certain options, please read the options carefully and you will be able to pick the right answer. Pelvic examination findings in a right occipito-posterior position will include all of the following except elongated bag of membranes, sagittal suture obliquely placed, anterior fontanelle felt near the sacroiliac joint, anterior fontanelle felt easily, or delayed engagement of the fetal head. What will you not see? डॉक्टर सनम 39 वीक्स का क्राइटेरिया है, रिकमेंडेशन है that if at all elective cesarean has to be done, it should be done after 39 weeks are completed to decrease the chances of transient tachypnea of the newborn. Okay, because what happens is that during the course of labor is a stressful condition for the baby also. So one final leg of pulmonary maturation also takes place during labor because steroids are released in the fetus. And secondly, you see the fetus's lungs, that they get squeezed while traveling through the birth canal, right? So the secretions in the lungs, they are eliminated. Okay, so that's why it has been suggested that if at all elective cesarean section, for example, if I have to do an elective cesarean section for a woman with previous cesarean section who's not willing for a vaginal birth after cesarean, I'll do it after 39 weeks are completed. Okay. So Raj Raghavan and Joseph answering the question, anterior fontanelle felt near the sacroiliac joint, that's the false statement, right? So this statement is false here. The anterior fontanelle will be felt near the symphysis pubis or it will be the posterior fontanelle. See, I'm talking about occipito-posterior position. So occiput is directed posteriorly, right? So it is the posterior fontanelle which is felt near the sacroiliac joint and not the anterior fontanelle. So let's just see here now. Have a look at this figure, that will make it more clear. So can you see here this figure here, guys? So we have this fetus here in the right occipito-posterior position. So this is the right side of the mother, right? So the back is towards the right side. The occiput is obviously towards the same side that the back is, right? And once you do a PV examination, on your PV, we try to feel the sagittal suture. So you can see that the sagittal suture is obliquely placed. And you can see this anterior fontanelle quadrangular space. which is directed towards the ischiopubic rami, and you have the posterior fontanelle, which is directed towards the sacroiliac joint, right? So on PV, what will we see? Sagittal suture obliquely placed and posterior fontanelle directing towards the right side here and towards the right sacroiliac joint here. So this is right occipito-posterior position, right? Now, another thing that I want to emphasize here is that on clinical examination, on per abdominal examination, you can recognize by performing the grips, which side is the fetus's back, which side is the limbs. It's the information you'll get the information that the head is in the is entering the pelvis, so you perform the pollic grip or the pelvic grip and everything, right? So what clue can you get on the per abdomen examination that will make you think ROP, that will make you think occipito posterior position? Any other clue? One clue is here, back on the right side, obviously. But back on the right side could be in right occipito anterior position also. So what is your clue on per abdominal examination that will make you think it could be occipito posterior position? Anybody, by looking at the figure, can tell me what would be the clue on per abdominal examination? I told you that performing the Leopold's maneuver will give you this information that the back is on the right side, the limbs are on the left side, the head is down, entering into the pelvis, that you can appreciate by performing the pollic grip and the pelvic grips. What other clue on per abdominal examination will you think it is occipito posterior, this thing? So Raghupati, yes, you would be able to feel these arms and legs, but on more superficially, any other clue? So that's so I think it should resume now. And since there will be a lag here, so I'm kind of figuring it out as I go along. It should resume now. So I have checked it and it's resuming and ready. Okay. So the ones who are still watching, I am so sorry regarding this I'm very sorry regarding this glitch. But the clue for the finding on per abdominal examination is the fetal heart sound. The fetal heart sound would be most prominent in the region of the flanks, right? So when it is an occipito anterior position, you see, whether it is of the left side or whether it is of the right side, the FSH is most prominently heard in the middle of the spino-umbilical line. So if this is the umbilicus, anterior superior iliac spine, if you join them together, it's here, right? So the fetal heart sound is most prominent when it's an occipito anterior position in the middle of the spino-umbilical line. But if you start feeling the fetal heart sound, if you start auscultating most prominently in the region of the flanks, then you have to think it is possibly an occipito-posterior position. Occiput towards the back side of the occiput towards the back. So the back side of the fetus is more here towards the flank of the woman. right? And see how the baby is kept. Baby is having arms in front of the chest. So when you auscultate with your stethoscope, you see, you're hearing the fetal heart sound with most prominence because it gets reflected. It is traveling across the fetal backside, right? So from there you hear it most prominently. That's why. Sadia, now is it clear to you why it should be most prominent in the region of the flanks? Because the backside is here towards the mother's flank, and fetal heart sound from the heart travels towards the backside here, and we can auscultate it because of that location. Okay. Now moving on, let's also elaborate on the other findings that were there in the question. So can you appreciate here that, this is a well-flexed head? Can you see this is a well-flexed head? On the other hand, if you see this figure here, the fetus's head is deflexed, right? The fetus's head is deflexed in figure number B here, right? So with a well-flexed head, which happens in a vertex position, and this is also vertex position. Both are vertex positions, but the difference is in the flexion of the head. So when it's a well-flexed head, it is the smaller 9.5 centimeter diameter which is entering the pelvis, which is the suboccipitobregmatic diameter, right? This is suboccipitobregmatic diameter which is entering the pelvis in well-flexed head, which is 9.5 centimeter diameter. Whereas when the head is deflexed, can you see, it is the occipitofrontal diameter, larger diameter, 11.5 centimeter diameter. Occipitofrontal diameter which is entering the pelvis. This is larger, 11.5 centimeter, right? So what we appreciate here, that we can also find a deflexed head in a case of ROP position, right? Because why does ROP position happens? ROP के दो main causes है. The causes for ROP position are two main causes. One is an android pelvis, right? An android pelvis which is more like the male pelvis. So there is less space anteriorly because it is narrow anteriorly. It has a triangular cavity, right? So android pelvis has more space posteriorly, so head preferentially goes into the occipito-posterior position. And the other important cause of ROP is a deflexed head. If the head is deflexed, then larger diameters are trying to enter the pelvis. And we have just said that with, there's more space in the pelvis posteriorly anyways, right? Even in a normal gynecoid pelvis, which is oval, there's more space in the pelvis posteriorly. So in a deflexed head, there are more chances of finding the fetus in right occipito-posterior position or any occipito-posterior position. So it's quite possible that we might find a deflexed head on examination. That's another point to note. Now, let us see here. What happens, if you look at it here in this diagram, if I were to draw the cervix here. Okay, if I were to draw the cervix here. Now, the head is well applied to the dilating cervix. And what you will also see is that there would be a dense bag of membranes in front of the head, right? And this bag of membranes will be well supported by the dilating cervix, right? So head is well applied to the dilating cervix and there's a dense bag of membranes, right? Well applied head to the dilating cervix and there is a dense bag of membranes in front of the head. Whereas when there is a deflexed head, so if I were to draw a cervix here, because the head is deflexed, it is not well applied to the dilating cervix. And if you were to look at the membranes, you would feel that the membranes are loose and hanging. Okay, membranes are loose and hanging rather than being a dense bag of membranes. So another clue which we find in PV findings in a case of occipito-posterior position will be a head which is not well applied to the cervix, head not well applied to the dilating cervix, There is a loose hanging bag of membranes, right? There is also a loose hanging cervix. The cervix will not also dilate properly because the head needs to be well applied to the cervix to help the cervix dilate. There has to be a tense bag of membranes which acts like a wedge to help the cervix dilate. So in women who are having labor in ROP position, right, what can happen? This loose bag of membranes can rupture, right, and it will lead to premature rupture of membranes. What can also happen is that the labor progress is also slowed down, because the labor will progress only when the head will flex again, right? So when the head will flex, it will again become well applied and then it will dilate the cervix. If it continues to remain deflexed, then the labor will become slower for women in ROP position. Okay. And now if you look at this diagram here, can you see this is the occiput anteriorly? When I'm doing a PV, which fontanelle will I palpate first? You can see I'm palpating the posterior fontanelle easily, right? In a well flexed head, you see anterior fontanelle here. Anterior fontanelle is higher and posterior fontanelle is lower. So if I to do a PV examination, when I go digitally like this, I will be easily feeling the posterior fontanelle. So here in the occipito-anterior positions, we feel the posterior fontanelle easily on PV examination, right? And in the case of occipito-posterior positions like this, can you see occipito-posterior positions? It becomes easier to palpate the anterior fontanelle on PV examination. So it is the anterior fontanelle, as you can see here, which is getting palpated more easily in occipito-posterior positions, right? So keep these important points about ROP position in mind, right? So let us go back and look at the options again. Elongated bag of membranes, true. Sagittal suture obliquely placed, true. Anterior fontanelle felt easily, true. And delayed engagement of the fetal head, because the head will engage, that means the head will drop down into the pelvis, it will come all the way to the ischial spines, the largest biparietal diameter will cross the pelvic brim with ease as and when the head is going to get flexed again. So engagement can be delayed, even progression of labor can be delayed in these women, right? So option number D, delayed engagement of the fetal head, is also a true statement here, right? Now, what will be the course of action? How will labor progress for majority of the women in occipito posterior positions? So to answer that question, let us see this question first. Which of the following factors tend to increase the duration of labor? Increasing parity, occipito-posterior position of the baby, well-flexed head, or ambulation during labor? Yes. So Stanley and Aisha answering and Sadia answering. Very good. So because failure to progress can happen with occipito-posterior position, it will tend to increase the duration of labor. Increasing parity. By multiparous women, they have a faster labor, don't they? Multiparous women, they progress faster. So increasing parity shortens the duration of labor. If it's a well-flexed head, going back, these are certain important concepts which you should remember. Very, very important conceptual understanding here, guys. If it's a well-flexed head, the smaller diameter, suboccipitobregmatic diameter are trying to enter the pelvis, right? So head cuff flexion and descent, they both happen simultaneously. So with well-maintained flexion, head will find it easier to come down into the pelvis. With well-maintained flexion of the head, there will be internal rotation of the head, because baby does not deliver in this transverse position, does it? It will deliver occipito-anteriorly like this, right? So there has to be anterior rotation of the occiput, right? So this occiput, whether it began from the right side, whether it began from the left side, talking about occipito-anterior positions, left occipito-anterior or left occipito-transverse positions. In a well-flexed head, the occiput will rotate anteriorly and then internal rotation will happen. If it's a right occipito-posterior position, let's go back to that. If it's a right occipito-posterior position, can you see here? This occiput has to come like this. It has to rotate. This is the occiput here. It will rotate 1/8 of a circle, 1/8 of a circle again, right? So can you see how the baby is rotating? Right? So from being right occipito-posterior, the baby's head is rotating, becoming right occipito-transverse, then right occipito-anterior, then occipito-anterior. And then the baby will deliver, right? So it is a long journey, a long rotation. If it had begun like this, if the occiput was like this, posterior fontanelle here, anterior fontanelle here, supposing this was LOT position, then the occiput needs to rotate only this much, right? 1/8, 2/8 of a circle. If I divide it into 8 quadrants, 1/8 and 2/8 of a circle. That's all it needs to rotate from the LOT position. Then it will become here, occipito-anterior. But when the labor starts from ROP position, there is a long rotation. You see, 1/8 of a circle, then another 1/8 and another 1/8 of a circle, right? So there is a long rotation and that will take time. That will take time, but for majority of the woman, this would be the outcome. So in occipito-posterior position, guys, if you were to look at my fist and this is the occiput on the right side, then this occiput will rotate 1/8 of a circle, ROT, another 1/8, ROA, another 1/8 occipito-anterior. So total of 3/8 rotation. Total of 3/8 rotation of the occiput, Dr. Aisha, there. Keep that in mind. All right. So this would be the total rotation in ROP and it will take longer. All right. Now for majority of the women, this is a very good outcome. Don't you think? It will take time. It will take time, no problem. But it will happen and the woman will deliver vaginally, normally, right? So for majority of the women, this favorable outcome will be there, right? As long as the pelvis is adequate, the pelvis is spacious, it is a normal gynecoid spacious pelvis, as long as the head maintains its flexion. Now, how will the head maintain flexion? During the course of labor, how will the head maintain flexion? I told you, if it has to be a well-flexed head, then only it will undergo all these favorable internal rotations. What will happen what will maintain the head flexion? Very good, contractions. Contractions, it would be uterine contractions. So with effective uterine contractions, which help in maintaining head flexion, majority of the women will have a normal outcome, right? And Sadia, why less rotation in left occipito-transverse? If this is the occiput, look at my fist. If this is the occiput on the left side of the mother, and that occiput has to rotate anteriorly, becoming occipito-anterior, and then only delivery will take place, then it has to rotate 1/8 and 2/8 of a circle. If it is left occipito-anterior to begin with, only 1/8 rotation, right? So remember that. That's why less rotation in cases as compared to as compared to left, as compared to right occipito-transverse positions. Okay. Sadia, is that clear now? Now, Sometimes what can happen is that your labor might get arrested. Okay, sometimes in ROP position, what can happen is for most of the women, the total rotation will take place. Sometimes there can be incomplete rotation also, right? Like for example, labor progressed till here, it became ROT and then it got stuck there. Sometimes it became ROA, then it got stuck here. So there can be various possibilities with ROP position. Let me just give you a brief overview of those possibilities. So this is where we all began. This is the right occipito-posterior position. Can you see? Now after this, if there is persistent deflection of the head, right? Head was supposed to get flexed. It doesn't get flexed. Or if there are weak uterine contractions, or sometimes if there is a big baby, or there is CPD, cephalopelvic disproportion, right? And if there is a faulty shape of the pelvis, right? Like for example, there is an android pelvis or there is an anthropoid pelvis, right? So the shape of the pelvis is not the normal gynecoid pelvis. In these situations, unfavorable outcomes can also happen. Like for example, if there is mild deflection, okay, there's only mild deflection, what can happen? The head will rotate only one bite of a circle. So ये यहाँ से it goes become right occipito transverse, and then it can have a deep transverse arrest. यहीं पे अटक गया. This is what we call as a deep transverse arrest. After this, the labor doesn't progress. And it is more likely to happen with an android pelvis, because in android pelvis, anteriorly there is less space. Okay, it's from, if you look from posterior to anterior, the android pelvis is triangular. Inlet is triangular, narrow anteriorly. And if there is moderate deflection, of the head, then what can happen is non-rotation. ROP, it's just stuck at ROP. It doesn't even rotate at all, right? So this is failure. So with moderate deflection, what can happen? Absolute non-rotation of the head, which is called as oblique posterior arrest. And with severe deflection on the other hand, sometimes there can be severe deflection of the fetal head. But if with severe deflection, what can happen is that instead of the occiput rotating anteriorly, have a look at it here. Occiput was supposed to rotate anteriorly. Instead, this occiput from here, this occiput from right occipito posterior to here, occiput rotated posteriorly instead. Now this becomes an occipito posterior position, which is direct occipito posterior position, right? So it becomes a direct occipito posterior position, right? So these are unfavorable outcomes with ROP position. They will happen if there is persistent deflection of the head does not get flexed during the course of labor, there are weak contractions, or if there is a CPD, big baby, faulty shape of pelvis, then such events can happen, like deep transverse arrest or absolute non-rotation of the head in the oblique posterior position, right? And sometimes there can be direct occipito posterior position also. Now in most situations, women with deep transverse arrest or with absolute non-rotation of the head is not budging, kahin nahi ja raha, it is not rotating, right? Then in those situations, they end up having a cesarean section. Eventually, because their labor is stuck, right? Now, what about direct occipito posterior position? Is there delivery possible with a direct occipito posterior position? Lou, I will answer your question, just a moment. Is there a direct occipito posterior delivery possible? Think again, Aisha. If I'm asking you such a leading question, yes, you can apply vacuum also. You can apply vacuum or forceps, but then the criteria for vacuum and forceps should be fulfilled. And the other criteria is pelvis. Pelvis should be adequate. So spontaneous delivery is still possible in a direct occipito posterior position. Have a look at it here. This is occiput here. This is the face of the baby towards the anterior fontanelle towards the symphysis pubis. And this is the posterior fontanelle towards the backside, right? Towards the sacrum. So this is direct occipito posterior position. What is happening? I'm telling you, it is already direct occipito posterior. So can this baby deliver vaginally? ये तो deliver कर ही रहा है in the figure, right? It can only happen with an anthropoid or a spacious gynecoid pelvis. Okay, so it can only happen with an anthropoid pelvis. Anthropoid pelvis are those types of pelvises which are anteroposteriorly oval. They have a lot of space in the posterior pelvis. So anthropoid pelvis or big spacious gynecoid pelvis, and if there is no cephalopelvic disproportion, then they can deliver, and this kind of delivery is called as face to pubis delivery. Okay, so normal vaginal delivery, if you have seen videos of normal vaginal delivery, if you've seen deliveries in your labor rooms, you know that the occiput comes out first and the baby comes out like this. Here this is different. Face to pubis delivery can happen in direct occipito-posterior position, but only if there is a spacious anthropoid or gynecoid pelvis and there should be no CPD, right? Then they can have this face to pubis delivery, right? Yes, it is still vertex. It is still vertex. The presentation is vertex. Vertex is this, Baba, the quadrangular space in between. This is the vertex. This whole thing is the vertex. In the vertex, there can be occipito-posterior positions. There can be occipito-anterior positions. All right? If deflexed, बच्चा, if ये तो deflexed ही तो है. This head is deflexed. This head is deflexed. What is this diameter? Have a look at this diameter again. Have a look at this diameter again. This is occipitofrontal diameter. Can you see? This is the occiput here. This is the midpoint here between the two eyebrows. This is your occipitofrontal diameter. This is the diameter of the deflexed head. Right? This is 11.5 centimeter. Just because the woman is having an anthropoid pelvis which is spacious or a spacious gynecoid pelvis, such large diameters are able to deliver, right? And when that happens, you see, there's more stretching of the vulval outlet. So with face to pubis delivery, there is always more risk of having perineal injuries. There's always more risk of having perineal injuries during the course of vaginal delivery. That is always the possibility. That risk is always there because a larger diameter is distending the vulval outlet. In a well-flexed head, like this, the diameter that is emerging out of the introitus is the suboccipito-bregmatic diameter. This one here, 9.5 centimeter. Right? So normally during the course of labor, with a well-flexed head, smaller diameters are entering the pelvis, smaller diameters are exiting the vulval outlet. With deflexed head, larger diameters are trying to enter the pelvis and larger diameters are exiting the outlet, right? So these are the important key points to remember from ROP position. Now, Lou, you were asking me what affects the direction counterclockwise or anti-clockwise rotation. See, let me go back to the figure here again. All right. Internal rotation is always described towards the symphysis pubis. So for laborers which are beginning from the left, occiput moves towards the symphysis pubis. Internal rotation is always described towards the symphysis pubis. In labors which are beginning from the right side, what if it's a right occipito transverse position to begin with, or a left occipito or a right occipito anterior position to begin with? Then the internal rotation is always towards the symphysis pubis. Whether from the left side, whether from the right side, internal rotation is described as rotation of the occiput towards the symphysis pubis. Okay. Now, moving on to the next question. All right. A 30-year-old 5th gravida para 4 live 4 unbooked woman comes to the LR in active labor at term. On PV examination, the cervix is 6 centimeter dilated, fully effaced, and you can feel the nose and mouth. You are concerned because this can be associated with what condition? Yes. Hydrocephalus, prematurity, placenta previa, oligohydroamnios, or anencephaly. Very good, Aisha, quickest there. So you're seeing a multiparous unbooked woman. Unbooked meaning she's had no prenatal care. She may not have even have an ultrasound done earlier. On PV, she's 6 centimeter dilated. You can feel the nose and you can feel the mouth. So this is face presentation of, right? You're feeling this part. So this is face presentation, and you are concerned particularly in this case because one anomaly which is associated with face presentation is your anencephaly, right? So anencephaly is associated with face presentation. I mean, there are other risk factors also, like prematurity is also a risk factor for having face presentation. Multiparity, prematurity, these are also risk factors for face presentation. Other than that, if you look at a figure here like this is the face presentation that I'm describing to you. Sometimes, you can see how face presentation has happened. Can you appreciate the neck here? There is complete extension of the neck. There is complete extension of the neck here. Complete extension, right? And such severe degrees of extension are often seen when there is a platypeloid pelvis. So another important cause of a face presentation would be the pelvis. Pelvis that is associated with face presentation is a flat pelvis. Flat pelvis. So the pelvis is flat, you see. And in an attempt to enter that flat pelvis, the head has completely deflexed. Complete extension of the fetus neck has taken place. So a flat pelvis or a platypeloid pelvis is also associated with face presentation of there is a thyroid tumor. Let's say there is a thyroid tumor here or a thyroid mass here that is preventing flexion of the baby's neck, right? Or there can be multiple loops of cord around the baby's neck, which can prevent the head from flexing. So these are the important causes to remember about the cause of faces presentation, right? Now another important thing here to remember, Dr. Sanam, cystic hygroma में swelling पीछे भी होती है, right? However, yes, it can predispose to neck getting extended. So I would give it to you that. Now the other thing here is, what is the diameter? What is the diameter of engagement of the fetus's head? Which diameter of the fetus head is trying to enter the pelvis? Can you see this? Have a look. I'll just draw it for you. This diameter. Can you see? Which is this diameter? Very good. This is Sadhya. Occiput ye hai. This is the diameter that is entering the pelvis. The diameter that I have drawn for you. What is this? It is 9.5 centimeter and it is the submentobrachmatic diameter. Submentobrachmatic diameter. Right? So this is the diameter of engagement in the face presentation. Submentobrachmatic. Right? Two diameters where brachma is there is the suboccipitobrachmatic, which is in the occipito anterior positions. Right, vertex occipito anterior positions, that is also 9.5, and you have your submentobrachmatic, that is also 9.5 centimeter. Both these diameters are 9.5 centimeters. Okay, now let's have a look at the next question. A senior reviews your findings and confirms face presentation with the chin towards the maternal symphysis. The membranes are present. Clinical estimation of fetal weight is around 3 kgs and the CTG is reassuring and she's getting moderate contractions. What is the appropriate course of action? Aisha, can you tell me the mode of delivery now? Can you guess the mode of delivery now? Perform a cesarean delivery, allow spontaneous progression of labor, oxytocin infusion till head rotates to vertex, or perform an ARM. How have we judged? Yes. So your chin is towards the maternal symphysis. It is mento-anterior. Mento-anterior position. Their vaginal delivery is possible. So we allow for spontaneous progression of labor. If the chin is directed posteriorly towards the sacroiliac joint or towards the towards the sacrum, if it's mento-posterior and if it's persistent mento-posterior in labor, it can rotate just like ROP. Mento-posterior can also rotate anteriorly. सारे डिलीवर्स हमेशा एंटीरियर रोटेशन के बाद ही होते हैं. If it's persistent mento-posterior, then there is no vaginal delivery possible. Then you have to go for a cesarean section only. Okay, right? There is no need right now to do a cesarean delivery. Vaginal delivery is possible. This one here is chin towards the maternal symphysis is mento-anterior. There is no need for oxytocin infusion. She is getting moderate contractions. There is no indication. There is no indication right now for oxytocin infusion. It's not like her labor is progressing slowly. There is also no need to do an unnecessary artificial rupture of membranes. Let her go into spontaneous labor. Right? Now, moving on to the next question. And I think this is your last question of the day. An unbooked multiparous woman is admitted at advanced labor at term. Sadhya, I'll take up this question also in the end. An unbooked multiparous woman is admitted in advanced labor at term with breech presentation. As the buttocks, legs and trunk deliver, you notice spina bifida. You assist the delivery of the arms, but head fails to deliver. What could be the likely problem? Hydrocephaly, fetal goiter, incompletely dilated cervix or placenta in the lower segment. Very good, Dr. Stanley, Aisha and Abhinav. It's possibly a hydrocephalus, right? Two things, hydrocephalus, large head, increased head circumference, right? Increased biparietal diameter, right? And the association of hydrocephalus with spina bifida. I mean, the head can fail to deliver. See, the buttocks and the trunk and the arms, they've been squeezed out. They can get squeezed out even through an incompletely dilated cervix. Even an incompletely dilated cervix will have the consequence of the head getting stuck behind the incompletely dilated cervix. But in this question, you have noticed a spina bifida. So that raises the possibility of association with other neural tube defects and other CNS problems, right? So there is a possibility of hydrocephalus here, and that is why the head has failed to deliver. Right? If there has been a placenta in the lower segment here, then it will prevent the delivery of everything else. No, why only will it affect the delivery of the head? Right? So placenta in the lower segment is not the answer. And like I told you, fetal goiter, fetal neck swelling is mostly associated with, you see, your face presentation, not with this breech presentation. And moreover, you can argue that if there is a neck swelling there and there's the fetal goiter there, then also the head can get stuck. I agree. But then again, the association with spina bifida is more likely pointing towards the possibility of hydrocephalus rather than a fetal goiter. Right? So for these reasons, the answer here is option number A, that is hydrocephalus. Yes, in hydrocephalus, Dr. Sanam, there is increased CSF. It is associated with ventriculomegaly. There can be, the obstruction can be at various levels in the CSF outflow tract, and that is a component of, sometimes a component of major unassociated CNS abnormalities also, could be isolated. So there are many reasons for that. And yes, association with neural tube defects also is there. Okay. So that's why the best option to choose here is hydrocephalus. Now I will take up Sadia's question, how to deliver the chin or the face. Okay, now when you are having a face delivery, you see, it is conducted along the same lines, right? But please remember that as you're conducting a vertex delivery, so there's no change in the way you conduct the delivery, right? But please remember that the head in a case of face delivery delivers by extension. So if there is a face delivery, we have to promote the extension of the head then in that case, right? Because the head delivers by, the head opposite, the head delivers by flexion in case of a face delivery. So normal delivery, head delivers by extension, right? In a face delivery, your head is already extended, right? So once this head is going to come out of the pelvis, the neck is going to flex, and flexion of the head will happen to deliver the baby out of the vaginal introitus, the final leg, right? And there you have to promote the flexion of the head. Only that difference would be there. So any more doubts and queries regarding today's session, guys? And you can put them on the chat box. And tomorrow again, same time on YouTube, 4 p.m. I'll be taking up another mixed bag MCQ session. Same time at 4 p.m. tomorrow on YouTube. And again, tomorrow, guys, at 8 p.m., there is a special class that I will be taking on the Unacademy platform, where I will be taking MCQs on infertility. Okay? And regarding other questions, if not spina bifida, Aisha, that is what you're asking. If not spina bifida, we can think what? We can think the possibility of other problems, right? If not spina bifida, understand here, the question is being asked in a manner is that you happen to notice a spina bifida. That's why you're thinking more in the possibility of hydrocephalus. If at all you're conducting a delivery in an unbooked patient, you don't know anything about that patient, you have no previous scan reports available, and the head fails to deliver, there can be n number of causes for that, right? So there could be hydrocephalus, there could be something obstructing the fetus's neck here, there could be a fetal goiter, right? There could be an incompletely dilated cervix, right? Or there could be, there could be an incompletely dilated cervix in that situation. So you have to think, just because in this question that mentioned your spina bifida, that's why you were thinking more in the direction of hydrocephalus. Or it could be plain and simple extended head. It could be plain and simple hyperextended head. Because the head is extended, larger diameters are trying to enter the pelvis. So after coming head of breech, if the head is hyperextended and not flexed, it will not come down, right? So that could be another reason. In fact, these are more common reasons. Incompletely dilated cervix, head already hyperextended. So in the first question, Aisha, when we discussed if there is a hyperextended head, stargazer breech, we were doing a cesarean section. Exactly because of this reason. That if the head is already hyperextended, it's a stargazer breech, then I'm anticipating that the head might get stuck during the course of vaginal delivery. So I'm doing a cesarean section, right? Now, Sadia, what will be the management in a case of hydrocephalus baby when the head gets stuck? If there is a head that is stuck, one can see if it's because of an incompletely dilated cervix. If it's because of an incompletely dilated cervix, one can give an incision on the cervix that is called as a Dushan's incision, given at 2 o'clock or 10 o'clock position to facilitate the delivery of the aftercoming head. If the cervix is completely dilated and the head is of adequate size and there is no hydrocephalus, right? Then one can apply the Piper's forceps, flex the head, and then deliver. The other option is one can also go for the maneuvers of the delivery of after coming head of breech, which are the Morisot smelly wheat, right? So when you conduct delivery by these maneuvers, you see, you are naturally promoting flexion of the head, like Morisot smelly wheat, which is described as, it's very difficult to give you all this information without diagrams, but I'm giving you a brief overview, Sadia, since you asked that what could be the management if a head which is stuck. So you're going to go for the maneuvers which are like Morisot smelly wheat, that will help you maintain flexion of the head and deliver the head out. That can be done if the head is extended. The other option is sometimes if there's a huge hydrocephaly, especially in such a situation when the woman is multiparous unbooked. I don't know what kind of neural tube defect this baby has, and now the head is stuck. Unfortunately, under those certain dire circumstances, when your maneuvers are also failing you, maybe then yes, it is justified to go for introducing a needle in through the posterior fontanelle and drain the excessive cerebrospinal fluid out and decompress the brain. So decrease the size of the hydrocephalus and then promote delivery. Of course, this would entail a significant risk to the fetus, but अब क्या करें? We have to deliver the baby. The other thing is, if you are trying a cephalocentesis through a posterior fontanelle, that might also not always be possible if the head is too high. So one can do an ultrasound guided per abdominal paracentesis. So all these are options which are explored under under these dire circumstances. But yes, keep in mind that the longer one takes to deliver a baby in these situations, the more the risk of having an asphyxiated newborn, don't you think? Right? And Dr. Saima, you want a detailed lecture on malpresentation. Well, I can see that you guys are having a lot of doubts about malpresentation. So we could have a detailed presentation on malpresentations as well. So if you want, if you guys are up for it, we can do all of these malpresentations singly as well. Like one day we can talk about breech, then another day we can talk about the face presentation and all of these things. So after tomorrow's MCQ session, for the rest of the days in the month of February, we can arrange for a lecture on malpresentations also. Saima and Dilveen, you are rightly saying put suprapubic pressure for flexion of the head. That will be done by the assistant. Yes, of course. So all these are maneuvers. I think I will have to now, since you are having so many doubts about this, have to arrange for another session for you guys about breech deliveries, where we can talk about these maneuvers in detail. All right. So thank you so much, guys. And Sadia, 8 p.m. wali class you couldn't find. 8 p.m. wala class, bache, you have to go on the Unacademy platform. There is a link on the description box for this class on the YouTube. So you can follow that link and reach the site. By my name, you can search for the special classes. Okay, so you can search for the special classes there by my name. All right. So thank you so much, guys, and have a great day. And I'll see you tomorrow, same time at 4 p.m. for another mixed bag MCQ session. And after that, we can arrange for a session on malpresentations as well.